Hello, everyone. My name's David Armstrong, and I'm the Director of the Health Workforce Technical Assistance Center. Welcome to our webinar series today. Today's event is entitled The Change in Public Health Workforce. Let me go ahead and introduce you to today's speakers. Today, we're joined by J.P. Leider and Janette Dill, both from the University of Minnesota School of Public Health, Division of Health Policy and Management. Welcome, J.P. and Janette.
Thanks to everybody who's going to be with us today talking about the changing public health workforce. Our presentation will be in two parts, where we're going to do a little bit of introductory material about the public health workforce, and then we'll get into some highlights about the HRSA and CDC funded Public Health Workforce Research Center and our year one activities. I'm JP Leider. With me is Dr. Janette Dill. Let's get into it. So this Public Health Workforce Research Center and its activities are run out of the Consortium for Workforce Research in Public Health, which is a 6-university, 10-partner consortium funded by HRSA and CDC through a cooperative agreement. The universities and colleges here are the University of Minnesota, Columbia University, East Tennessee State, Indiana, Johns Hopkins, and the University of Washington. We have a number of partners as well, and our partners come together to support us to look at identifying topics that are critical to the public health workforce every year. And one of the things that we start by doing is trying to decide and kind of circumscribe what is public health and what is the public health workforce. So that's one of the things we want to start by doing today. It's not to exclude workers or topics or activities, but to ask the question, what is public health? Because definitions really matter. So this is an example where we're going to start by looking at 50 years of federal outlays to states and ask the question, how does our vision or our understanding of what public health activities are by looking at expenditures change by who we include or who we exclude from what is public health activity? So you'll see here in the chart, in the blue is CDC and in the red is HRSA. And so for the sake of argument, we're going to be including everything that an agency does. For the example, understanding that within agencies, of course, there's lots of different activity. So starting kind of non-controversially with our two federal agencies here, you can see there's a lot going on in the 60s through the early 2010s. But what happens when we add more agencies? There's, of course, many federal entities doing public health work, right? What happens when we include FDA or EPA or SAMHSA? I think there would be reasonable conversation that we might have about how much of those agencies I just listed are doing public health activity. EPA is a good example, right? What proportion of their activities is protecting the environment from people versus people from the environment? But for the sake of argument, again, we're going to just include them to show what the change of scale might be. You can start to see the axes shift, and we start to see that CDC and HRSA becomes a smaller and smaller percentage of that pie. As we continue with the example, and we include things like the NIH or Food and Nutrition Services, again, there's this argument to be made how much food insecurity affects the public's health. But should not just WIC or SNAP or other kind of food and nutrition services that we might provide to children at schools, right? Traditionally not included. But if you were to include that as a public health expenditure or activity, it's a little hard now to even see CDC or HRSA's share of the so-called pie. And then to kind of take this to the logical extension, what about the Centers for Medicare and Medicaid Services? There is no question that what they do impacts the public's health, right? Population health is deeply impacted by the activities of this large federal agency. But again, to the extent that this is included, our first example is now unrecognizable. So the idea here is not to say that one thing is public health and one thing is not, but the idea instead is to say it is important to be very specific when we're talking about particular projects or using particular definition sets to say what your definition set is so that we can be on the same page. So for today, we're talking about public health activities as governmental public health activities delivered by state and local health departments. And we're going to talk about these through the context of workforce problems, composition and enumeration problems, what we'll call pathway development problems, sometimes called pipeline development problems, and recruitment and retention problems. These have been talked about somewhat in our recent annual review of public health paper, which we're happy to send out as a resource as well. So we'll do this at a somewhat high level. In terms of composition and enumeration, the idea is how many people do we have working in public health, state, local, federal, and the challenge is we don't necessarily know. Going all the way back to the 70s, there have been calls to really try and understand just how many people work in state and local health departments. And the problem is that unlike dentist's office, clinics for primary care, hospitals, things that are tracked by the Bureau of Labor Statistics, the state and local health departments are not tracked by federal statistical agencies. And this has long been true, continues to be true. So before COVID, during COVID, and now through this kind of COVID recovery period, we're just not clear exactly on how many people work in governmental public health units, unless we're able to do what are these kind of so-called synthetic enumerations. We pull together different data sources from the field, and we use what data sources are available because the federal government isn't able to provide that consistently year after year. And so every maybe 10 or 15 years, we get kind of a snapshot. So we had one in the early 2000s, one in 2014, and now we have one underway right now. The most recent one found something like 300,000 people working, federal, state, and local, about a little over 200,000 at the state and local level. And pre-COVID, this is approximately what the state and local public health workforce looked like. As you can see, kind of on the coasts following centers of population, local public health in the kind of yellow to brown is really what local public health looked like. And state health agency kind of central offices in my state, Minnesota, that would be our Minnesota Department of Health. Those really kind of vary wildly. They do track population size of the overall state, but not completely consistently, right? There is variability there. Some states have larger central offices, even relative to their population, some smaller. A lot of reasons for that. So there are about 2,500 local health departments in the country, local and regional, and they kind of vary widely in terms of serving county, city, multi-county, or complex jurisdictions. And you can see that there's kind of this wide swath in the middle of the country where it's mostly county-based that are much smaller, largely tracking rural and small jurisdictions. So the last thing that I'll mention in terms of composition and enumeration is that we have had some significant challenges with the workforce shortage question ever since the Great Recession. And previous estimates have shown that even prior to COVID, that shortage was a sizable portion of our overall workforce. Again, I said, just over 200,000. Estimates showed that we were about 80,000 short just prior to COVID, and then COVID hit. So I've already mentioned this issue related to not classifying the workforce. So I'm going to pass this up and return to the question of what would these workers that we're missing kind of actually do? So we're 80,000 short. What are we short in? We're short in leadership and management. We're short in kind of the professional and scientific, so the kind of public health sciences, EPIs, nurses, dietitians, but also in the technical and outreach side related to that. So this would be disease intervention specialists, community health workers, counselors, and so on. And then, of course, business and support services. When you kind of look at that as what I think is called a tree chart, if I remember correctly, you can see that we have a really diverse workforce nationally. There isn't like one single kind of worker we have. We're a field and not a discipline. So it's true we have an awful lot of proportionally public health nurses and related clinical workers. That's kind of the largest single occupation. But we also have a lot of clerical workers, environmental workers, DIS folks, and policy and data workers too. So it's really quite diverse. The other item that I'll mention quickly is that as we think about how to get and to keep these folks into the workforce, it's long been known that pathway, previously called pipeline programs, are a particular challenge. Historically, they've been talked about as needing to be created between schools and health departments or health agencies, and they tended to be kind of with a champion or a person in each agency. But when that person leaves or retires, or there was a grant and the grant goes away, that's been a problem, right? That bridge is broken. And so more recently, there's been an acknowledgement that there needs to be structures built that can outlast a person or a relationship. And there have been some investments in that, whether through a formal, what's called an academic health department structure, memoranda of understanding, or other funded mechanisms that set up those structures. So even if the funding weren't to be there, those structures could persist. This has long been called for ages ago, but it's taken a while for those formal structures to have some uptake. All right. As we think about what happens once those bridges are built, the challenge becomes not all of our grads actually end up going into the workforce, the public health practice workforce, I should say. Most end up going at the bachelor's level into for-profit organizations, which I'll say is kind of the norm for all bachelors. That's kind of true for all bachelors overall. But then follow that up with healthcare institutions, and kind of like near the bottom is government. For master's degree grads, it's similar: healthcare first, then for-profit, then government and academic institutions. So it's very different than when many of our longstanding programs began 4 or 5 decades ago, when government was near the top. That's really why our master's programs began way back when. But over time, as we've added more programs, as we've added more grads, really governmental public health as a first destination outcome has fallen to near the bottom as to where folks end up. So we've already talked about the workforce shrinking. We've talked about a number of the challenges to replace these workers. There are some new specific initiatives, both with respect to, I would say, college and university recruitment into the workforce, but then also outside of college. So the AmeriCorps program and other fellowship programs, I would say, are trying to kind of create a new workforce that does not presently exist. So that's something that is new within the last several years, and the question is whether Congress will fund it to continue. I think that's one of the big questions. The challenge that we're experiencing kind of with and post COVID-19 is we have all of the pre-COVID challenges, and then we have in terms of numerical shortages, stresses, and then we have COVID enter. We have harassment being reported, burnout being reported, frontline workers now experiencing and exhibiting post-traumatic stress symptoms and burnout in ways that had never been reported within the workforce previously. And before I hand it over to you, Janette, I think the last thing I'll say here is we're kind of at this inflection point where we recognize that there's this tremendous need for more workers. We have some skills and tools to have a large number of our grads potentially go into the workforce, but we're not presently doing a good job kind of converting those potential grads into employees for a number of reasons. And so I think what we're excited to talk to you about next are these various projects where we're going to talk about why that might be and what we might do to make that a little bit different going forward. So with that, Janette, why don't I turn it over to you?
All right. So as JP mentioned, JP is the director, and I'm the deputy director of the Consortium for Workforce Research in Public Health called CWRF. CWRF is a collaboration of researchers across 6 universities, and they are conducting research in a wide variety of areas. We're focusing on the healthcare workforce. So these researchers, and the reason I'm going over this again is because I'm going to present some of their findings, but they're coming from the University of Minnesota, Columbia, East Tennessee State, Indiana University, Johns Hopkins, and the University of Washington. So CWRF received funding from HRSA and the CDC starting in 2022. And today I'm briefly going to highlight some of our year 1 studies, which we've just completed. These include measuring turnover in the public health workforce, salary disparities between the public health sector and the private sector, and then state hiring laws. All right. So the first study I'm presenting here was conducted or was led by one of the researchers at the Center for Public Health Systems here at the University of Minnesota. Her name's Nikki Weiss. And it was entitled Harmonization of Public Health Workforce Survey Data on Employee Turnover. It focused on harmonization of public health workforce survey data across several different data sets. The goal of the project was to take turnover measures, namely intent to leave, as well as involuntary turnover and retirement, across a variety of public health data sources, to standardize those measures, and then to get some combined estimates for public health workforce across multiple data sets. So what do we find? Well, we found that a relatively high percentage of public health workers are considering leaving their jobs at 31%. There is a very low rate of involuntary turnover in the public health sector, which I think is expected. We think of especially governmental jobs as having a high degree of job stability, and we found that to be true. But less than 1% of public health employees were laid off in 2019. So who is more likely to plan to turn over or plan to leave their jobs? We found a reduced probability of leaving among Native Hawaiian and Pacific Islander folks as compared to white folks, people who are a little bit older, between the ages of 51 and 60 as compared to younger folks, and those who were age 61 plus. Those that had increased odds of leaving and exiting the public health workforce were those who identified as being multiracial, men as compared to women, non-binary folks, and then younger workers, which are always hard to retain. They're a tricky bunch. Retirement is an issue with the public health workforce, as it is across the healthcare sector, with a lot of the population planning to retire within the next few years. We found that 20% of public health workers are considering retiring in the next 5 years, and 36% of the workforce, which is pretty high, have taken steps to retire. Let's see. This is not what I thought it was going to be doing. I'll just move through that. Okay, there we go. All right, second study is salary. I don't know, JP. The remote control is, there we go. A little delayed. All right, there we go. Salary disparities in public health occupations, which was conducted by or led by Heather Krasna, who is a faculty member at Columbia University, and it focuses on salary differences between public health and the private sector. Okay, here we go. All right. The highest disparities were mainly for professional workers. So we found that professional workers in the public health workforce had a pretty significant wage penalty as compared to private sector workers. So those in management, those working in IT and computer, and those in research science kinds of jobs had salaries that were 20 to 47% lower when they were working in public health. So that's a pretty significant wage penalty. Workers in JP, I might have to ask you to switch the slides. It's like not really working. There we go. Okay. Workers who are in clinical roles also experienced a wage penalty, but it was a little bit lower at 10 to 20%. So among nurse practitioners, nurses, physicians, those who are working in the public health sector are earning wages that are lower than their counterparts working in the private sector, but the wage penalty isn't quite as severe as those who are in more sort of administrative professional roles. And then we found that there are actually some occupations that get what I would call a wage bonus when they work in the public health when they work in the public health sector. And these include workers who are in counseling and in social work, and those who are have lower levels of education and are in these tech and assistant type jobs. And I will say that the private sector is really, and sort of healthcare more broadly, does a really bad job of providing high quality jobs for people who are in caring occupations like this. And so this is an area where working in governmental public health, working for the state, working for a county actually provides workers with higher wages and better job quality. All right, the last study that I'm going to highlight from our year one studies was a review of state hiring laws for public health workers. So I think for those of you who are used to thinking about the healthcare workforce, this is something like we just very rarely think about. But many times, if you want to get a job working for for state government, for the federal government, for county government, you have to take a test, and you have to pass the test in order to be able to be considered for those jobs. And so Valerie Yeager, who is at Indiana University, did her first year study focused on reviewing state hiring laws and how that could potentially impact the supply of the public health workforce. All right, just as background, civil service laws are meant to prevent cronyism and insulate public employees from political influence. However, critics have argued that these laws impose an undue burden on hiring managers. Over time, civil service reforms have sought to expand managerial flexibility to hire and discuss employees. More current reforms attempt to improve personnel management and make government systems less rule-bound, more flexible, and more responsive. All right, so this map shows the states that require some sort of civil service exam in order to be eligible for public health laws. So you can see the ones that require an exam are in green. The ones that don't require an exam are in white. And then there are a couple states, including Alaska and Florida, where an exam may be required. All right, so the key takeaways from this study is that many of the laws that were reviewed lacked clarity, which may be difficult for agencies and for potential employees to navigate. Almost a third of states have laws that establish civil exam requirements without specifying the conditions for when exams must be required or for whom. Requirements for state laws or for state hiring vary across states. In the majority of states, another state body maintains the hiring list, and almost 70% of states require that a selection for new employees come from the list of those that have passed the civil service exam. This process can lead to a lot of confusion for potential employees in terms of how to get onto hiring lists, the time it takes to get onto the list, and how long one's name must remain on the hiring list before they might be eligible for a job. It's feasible that in the process of reviewing candidates when removed from the organization and management team that will employ the new worker, it is more bureaucratic and time-consuming. It makes it hard for public health agencies to move with speed and to be flexible in their hiring. And then recruitment of the most qualified candidates may not occur, as those individuals may not be in demand and may accept a job offer received quicker somewhere else. And this is something that we hear often from our graduates, is that they may attempt to be hired into a governmental public health position, but the job offer comes too slow, and at that point, they've already been hired into the private sector. Given the challenge, I guess I will say many public health agencies have also said that they have struggled to spend out funds that were provided through the American Rescue Plan post-COVID. Even when they did have funding, they struggled to hire new graduates or to expand their workforces. And part of this is the bureaucracy around hiring that exists for public health workers. All right. And then here I'm just going to quickly highlight some of our current projects that we are now conducting in our second year of funding. And I'll just quickly highlight 3. So I've listed out our 8 studies that have funding, although one of them I'll note is sort of like a 2 project package, and I'll talk about that one in a minute. But these are ongoing studies that we're conducting right now. So the first one that I'm going to highlight is the number 1, the implementation of evidence-based public health workforce loan repayment program, which examines the potential of loan repayment in encouraging public health graduates to go into governmental public health. As I'm sure many of you are familiar, there are loan repayment programs for lots of not lots, but for some occupations, especially in underserved areas, particularly in the healthcare workforce, but there isn't a loan repayment program for those going into public health. And so this explores the potential of that to encourage new graduates to go into governmental public health jobs. The second one I want to highlight is distinguishing characteristics of public health occupations compared with existing standard occupational classification codes. So these are kind of nerdy projects, but this is our double project. That's why it has a star next to it. In these projects, we are gathering information about public health nurses and disease intervention specialists with the hope of moving towards some new SOC codes for the public health workforce. As JP talked about earlier, the public health workforce is hard to enumerate in sort of standard population data sources like the Current Population Survey or the American Community Survey. In those surveys, we use census occupation codes, which are based on these SOC codes that are developed by the Bureau of Labor Statistics to identify what occupations people are working in. And in the CPS and in the ACS, it's quite easy to identify healthcare workers, but it's very difficult to identify those who are working in public health occupations. So these projects are trying to gather the information that would make it possible for them to for the BLS to create a new SOC code for public health nurses and for disease intervention specialists. These projects include identifying how the job tasks of these occupations are different than other job tasks being performed by other occupations, identifying professional groups, identifying training programs, and just making the case that they are indeed a specific occupation performing specific job tasks that are different than other occupations. And then finally, we have a couple of projects on public health nurses led by our colleagues at the University of Washington. LHDs consistently report that public health nursing is a very big challenge for them. So they struggle to recruit public health nurses, they struggle to retain them. I think public health agencies struggle to compete with the healthcare sector in terms of recruitment and retention of nurses. So understanding this workforce is really important, and we have two projects in this round of funding that focus on the public health workforce, including I believe it's number 5, the distribution of LHD nurses relative to local demographics, and then number 7, which is evaluating a minimum data set to characterize the public health nursing workforce. And that's what we got. It's time for some questions.
All right, thank you, Janette, and thank you, JP. You touched on it a little bit earlier in your presentation, but how is the public health workforce changing? That is, does the workforce look different now than it did prior to COVID? Could you maybe say a few more words about this?
Sure. I'll take that one first, and then Janette, please jump in. The workforce looks different in a couple major ways. The first is that we have more temporary and contractual workers than we did prior to COVID. The best estimates available suggest that the workforce is now something like 20% temporary contractual, whereas prior to COVID it was, I'm sorry, no, that's right, 20% temporary contractual, whereas prior to COVID it was more like 10% or even as low as 5% temporary contractual. And it differs based on setting, state versus local, with locals having more contractual or temporary workers. And so this is really relevant for new and younger staff trying to enter the workforce, right? They're more likely to have these kinds of positions. And so the experience of those, especially under the age of 35, where this might be their first job out of school or entering public health for the first time from another sector, they're much more likely to encounter non-permanent or non-full-time position, right? Since this is different. Now, this is because we have COVID money that's temporary. We have recovery money that was temporary. COVID response was just inherently very different than our normal public health funding as we surged to respond. We also have, because of that, a demand for a different kind of workers incrementally during COVID response, right? You have more preparedness folks and more like DIS types, disease intervention specialist types, and EPIs and so on than in the pre-COVID era. But that might not always be that way, right? As contracts run out, the workforce may again shift to look a little bit different. The question will be, what should either a post-COVID workforce look like, or maybe put more aptly, a COVID recovery workforce look like? And I think states are kind of reckoning with that right now. They're trying to figure out, what do I have and what do I need? to do public health in this kind of COVID recovery landscape. And I think what people are realizing is COVID made them realize they need a lot more than they had pre-COVID, and not just to surge, but to do the basics. Janette, anything for you?
Yeah, I mean, I guess one thing that I have heard from public health agencies is a couple things. One is that health agencies are moving more towards the delivery of population health rather than clinical care, which sometimes means a shift in the kind of workers that they're hiring and the kind of occupations that they have employed within public health agencies. They might not have public health nurses providing those, clinical on-site services anymore. And instead, they're going to be thinking around running public health interventions or, thinking about data and identifying, health disparities, things like that. And those changes, I think, can lead, like I said, to a shift in the types of occupations within health agencies. And JP's welcome to weigh in here on that. The other shift, I think, is that there has been a movement towards the use of community-based workers by public health agencies. And so that includes people like community health workers, lay and peer types of workers, lay counselors, peer counselors, things like that. And those, that can be a shift towards more engagement with communities, which can be really wonderful. It also can sometimes be a response to challenges in hiring public health nurses, right? And hiring people who have more credentials. And so that's just a shifting dynamic. JP, welcome to weigh
in. I don't have anything to add there. I think that was.
Okay, well, if y'all don't, then I have a follow-up question, if you will. I mean, really, what all do we know about this new workforce per se? And do you see this increase in like contractual positions? Is that gonna remain permanent now? Or do you see it kind of, decreasing over time as we move further and further along this like post, this COVID recovery landscape, as you refer to it?
Janette, would you like to go first, or shall I?
Go ahead.
So as of right now, David, there is no question that we are headed for a funding cliff federally. It's marked, it's on the horizon. And if it happens, the contractual workforce will shift, it will diminish. States and localities that have built a workforce around it, many are planning for that cliff. And it would dramatically shift the composition of the workforce. It would affect how our demographics look. Because people who are in non-permanent, non-full-time positions are more likely to be, under the age of 35, are more likely to be staff of color. And so it would shift the workforce away from racial and ethnic diversity among younger people. And the question kind of becomes, what do we do about that, or how do we think about that, or how do we handle that? And the answer isn't easy, and I don't think there's a single answer, to be honest. The problem is pretty systemic in terms of how we are funded, and I think that the answer probably needs to be the same. What I would say is, it seems like a lot of the choices that were made to provide one-time, very flexible money made and make a lot of sense, because otherwise we wouldn't have had any money to respond. Need to have sustainability behind them. And that contractual employees were kind of the logical extension of that, because most states or localities aren't allowed to hire permanently off of one-time money. So the shift is coming, it is known, and unless something changes, it'll be here in 2 to 3 fiscal years. Depends on the mechanism we're talking about.
Janette, do you have anything to add?
It's kind of a bleak picture.
Sorry.
Ouch.
No, I don't have anything to add.
Okay. What types of new and emerging occupations do you see within the public health sector emerging out of this new landscape?
I could go ahead and jump in here. As I said earlier, I do think the movement towards population health is changing the occupational landscape just a little. I don't think that governmental agencies change their occupations very quickly. I think it takes a while. But maybe you hire a data analyst, right? In order to be able to do some additional identification of health disparities within your community, right? Or maybe you bring on a new epidemiologist. As I said earlier, there's been an expansion of the use of community-based workers within public health agencies. So, I think that those are some occupations that are being used to a greater degree. But again, as I said earlier, they can be very hard for us to identify in the data because there's a lack of a code to identify public health workers. So there's some documentation on public health occupations, but it can be a little hard to pick up. JP?
I would say that the growth of community health workers, as you've pointed out, in the last 5 to 7 years has been the largest that I've observed. The segmentation of disease intervention specialists from other kinds of communicable disease workers has been really noteworthy even before COVID, but certainly since. The broader trend that we've seen in public health is kind of like a scope of practice segmentation that will be very familiar to healthcare researchers and people who have worked in healthcare and now work in public health, because it happened in healthcare like 35 years ago, right? Essentially, the idea is that you are either creating or modifying positions to allow folks to work at what's called like the top of their scope or the top of their practice. So like nurses, public health nurses can like focus on the top of their licensure, and you have other support staff that will allow them to do those things. And so it's not a particularly like novel concept, but it's a novel use case in public health that's been sort of inching in. And one of the challenges, I would say, Janette, that you know 100 times better than me, is that with community health workers in particular, you have both like the clinical support side of community health workers, and then you have the population support side of population-based support side of community health workers that can be kind of like in tension with each other. Because just like public health nurses have been asked to sort of like do everything for the past 60 years, community health workers are now sort of being tasked with the same, but at a different level of scope of practice.
Yeah, and I think I think this is true in healthcare as well. I think the role of the community health worker especially, as well as peer counselors, lay counselors, those types of workers are, you know, like that's still being negotiated. It's still being sort of, uh, you know, agencies are trying to figure out how to employ these occupations, how to bring them into the, you know, teams, places like that. So, you know, I think that anytime you have the sort of growth in a new and emerging occupation, you know, sort of figuring out the scope of that occupation can be a big challenge, as well as, you know, things like training requirements, you know, sort of expectations around education, career pathways, things like that. So, you know, I think that though that is an area where we will see a lot of, you know, we see challenges and we're just going to see some more standardization than we have right now.
All right, thanks, Janette. And once more, for those of you in the audience, you may ask questions using the Q&A panel. So by all means, don't be shy. With that said, a point of clarification for one of the studies you presented earlier regarding turnover. You mentioned that there's a high degree of turnover in public health, I think maybe 30%. And that is like these individuals in the turnover, they could be finding other public health jobs. Is that correct? They're not necessarily leaving the profession? Or do you know this?
Yeah, so I can speak to that.
Yeah.
So there's a difference between turnover intention and actual separations. In the case of this study, what we did was look at different data sources to try and identify kind of any concordance and discordance between turnover intention, actually leaving or actually separating, and then things like retirement eligibility, and so on. And then kind of there's a different study that was conducted with a different data source that we could validate against around actual separations, kind of during the COVID period. So for turnover intention, what we're essentially doing is, you know, at the base level, is looking at a data point that's asking people, you know, are you considering leaving in the next year for any reason? And in this particular data source that I'm speaking of, there's a separate question that says, like, are you planning to retire for any reason? And then it asks you, you know, like, in what year of the next 5 years are you planning to retire? So you can line up the retirement question and the leave question. And so are you planning to leave or retire? And if so, you know, it asks you why. You know, what are the reasons? Have you taken any steps toward doing so? And in the case of leaving, what are you planning to do when you leave? Just as you're getting at, David. So are you planning to leave for another public health position somewhere else? Are you planning to like leave government, you know, go to healthcare, go to a different, you know, essentially the positions? So you don't know where they end up, right? The downside here is your survey is going to people currently employed. You don't really have the opportunity for follow-up, but you can sort of surmise if they were to follow through, would you lose them from the workforce? You don't know for sure. But it does seem like a lot of the people who say they're thinking about leaving, a small slice are kind of moving to a grass is greener within governmental public health, but most are like trying to get out of the game.
All right. Thank you, JP. Do you have anything to add, Janette?
No, I mean, I think that turnover intent is a little tricky because it can be like a proxy for just like overall job satisfaction. You know, like people's ability to separate from their jobs kind of depends on how many opportunities there are in other places, right? And so like what the economy is like. And right now, there are lots of jobs all over the place, right? So like it's probably pretty easy to go get a job somewhere else outside of public health if that's what you want to do. But it sort of depends on like what the economic landscape is about whether or not people are actually able to leave.
Okay, thank you. And we do have a comment from Shirley. Let me go ahead and read it. And perhaps you'll have a reaction to it. In our present non-system, there is so little ability and awareness on how to deliver healthcare services, structure health services of which public health should be a part of, pay for them. Not sure anyone has a good integrated model. After 50 years in the health sector, it seems to be getting worse. once more a rosy picture. As JP hit on earlier. I don't know if you have any comments on that, but and thank you for the comments, Shirley. Okay.
Yeah, I mean, I guess Shirley, what I would say is there are points where it feels like there should be natural, if not integration, then greater awareness. And perhaps the most obvious, right, is between local public health and primary care, right? That's sort of the most natural example where people may not desire to actually like be truly integrated, but to have at least greater awareness of what the others are doing. But there are a lot of good reasons why that is very challenging, even though it makes a lot of sense to collaborate and communicate and to work together. There are kind of concrete ways where there are incentives and requirements, like around community health needs assessment and improvement planning and so on. But yeah, there are a lot of disincentives or perverse incentives that make it very challenging.
Okay, anything from you, Janette?
You know, I mean, I agree with all those things. I don't think there's no easy answers. But yeah.
Yeah. Well, we're almost at the top of the hour.
Mm.
And so I guess a final question would be, what's one takeaway you'd like your audience to come away from this event with today? What's one thing?
I can go first and then I'll let JP end. I think that the public health workforce, I'm a little bit new to this workforce. I'm someone who's been doing research in the area of healthcare workers for a long time, but I'm a little bit new to the public health workforce. And it's very different, right? It's very different than the healthcare workforce. Instead of a lot of clinical workers, you have many workers who are IT, data infrastructure, communications, epidemiologists, and so there is a clinical component to the public health workforce, but there are many other types of workers who make up the work of public health. And so I think, having an appreciation for the work that public health workers do, but also sort of the sort of different types of occupations that make up the healthcare workforce is really important. And to realize that the work of, promoting population health and promoting public health, it isn't just done by physicians and nurses, right? Like there are many varieties of workers in the public health workforce doing this important work.
So what I would say, David, is there's been a lot of things today that are, to use your phrase earlier, bleak, or the technical phrase super bleak. But there's a reason for that. The workforce, the public health workforce, had all the challenges that the private sector was facing during COVID, right? The great renegotiation and the great reshuffling and all of that. It had all of the challenges that the public sector was facing, right? With like the lack of surety about revenue and like things closing and all that. And then it had the very specific challenges of negotiating a pandemic response. And so the burnout, the harassment, the actual like being responsible for a societal response. It did this even though between 2008 and 2019, it had lost like 20% of its workforce. So, our workforce came in understaffed and was expected to respond to like hopefully a once in a generation or a century pandemic. But what I think people should take away is that this like super bleak period of time for the workforce and all of the burnout and all of the turnover and all the things that make sense, right? It makes sense that people would respond logically and burnout would occur logically because, employees are people and we should treat them like people. that it's performing this incredibly important function, and that we had a lot of folks continuing to stay and do the work, and that we still have people trying to join the workforce. And so we should figure out ways to make it easier as like a practical and administrative manner, even if it's really like boring and technical to solve those problems, so that the people who want to come and join the workforce can like do it and not hear 3 months later that, oh yeah, you should come and interview with us. Because it like, we should pay them more, right? We should pay people more, but it's not just about pay. It's about like the job applicant experience and how long it takes. And do they have to take these civil service tests, just like Janette was saying? There's like a punch list of things that people can do that go above and beyond pay to get more folks in the door. And I think if we did that, we would be much better off.
Well, thank you.
Sure.
I did have one more comment here, and a follow-up to the previous comment, and it surely agrees with your previous statements, but not sure what primary care means and to whom. With CVS and Amazon and healthcare delivery services, what can states do? Another bleak or technically super bleak? Is that?
Yeah, I mean, we can get cheap. The states can get cheap prescription drugs from Amazon, I guess, just like the rest of us.
There we go. That's the solution then. Okay, well, we're right at 3 o'clock. It was a wonderful presentation. Thank you for being on here with us. It's much appreciated. Hey, I hope to hear from y'all again in the future. And for those in your audience, thank you for attending.